and we are really, really privileged to have Dr. Coll with us. I'm going to read her profile and also introduce Alan. Professor Alan Stein was supposed to facilitate the session today, but you have me, so lucky you. But we're really, really lucky to have Dr. Coll here with us today. She's a researcher with training in epidemiology and strong interests in investigating health inequalities, as well as understanding the determinants of violence within families. She completed her PhD 6 years ago at Oxford, right?
Part in Oxford.
Part in Oxford. And she holds a Wellcome International Training Fellowship Award to study the effects of domestic violence on parenting and child development, and has been working as a postdoc fellow at both the International Center of Equity and Health and Human Development and Violence Research Center at the Federal University of Pelotas, I had to practice that, in Brazil. And Dr. Coll uses observational, particularly cohort studies and cross-sectional nationally representative surveys to investigate her research questions and provide evidence for policy and practice. Welcome.
Thank you, Jen.
We're very, very happy to have you. And Professor Alan Stein, who is online, who was supposed to facilitate the session, said that I should say one line about him, that he's been in Oxford for 3 decades, maybe 4, he is to confirm, but he is currently the Senior Research Fellow in Global Health and Public Policy at the Blavatnik School of Government. And for most of us in this room, you'll know that he was the former chair in child and adolescent psychiatry. Okay, so Dr. Coll, over to you. I will just say, in terms of keeping protocol in this room, how we want to run the session, Carolina is very happy to take clarification questions during her presentation, but please keep the substantive questions to the end of her presentation. Over to you.
Thank you. So thanks, Jen, for the very kind introduction. And to replace Alan here, Alan, really sorry that you couldn't come in person, but I should say that I first met Alan in 2015 when I came to do part of my DPhil in Oxford under his supervision at the psychiatry department. And that turned into a long-standing collaboration and partnership, and I'm really glad for this. So today I'm going to talk to you about intimate partner violence in low and middle income countries, sharing inequalities more on a global health perspective, and then entering a bit more on findings from birth cohort studies, where we can say more about the impacts on children. So, and more specifically, in my context in Pelotas in Brazil. So just to kind of have a better idea of where I come from, and because some of the findings I'm going to talk about to you come from this setting in particular. So I come from this city called Pelotas. It is located in the extreme south of Brazil, so very close to the border with Uruguay. And it has a population of about 340,000 inhabitants. We can say, although the south is the most developed state in Brazil, we can say Pelotas is a relatively poor city in the state. So here is where it is located, our epidemiology program. And some of, not sure if you heard about, but some of the longest ongoing birth cohorts in the context of low and middle income countries. So this is Pelotas. Just a parenthesis, but allow me to show you that just before I came, so a month ago, Pelotas has been reached by unprecedented floods that committed all the state of South in Brazil. So like hundreds of cities, and now we have millions of families that lost everything they had this past month. And I'm just saying this because it's very important for what we are talking about today. And we as researchers, we need to think how to address violence in these contexts as the effects of climate change are becoming more and more present. So, but back to what I'll be sharing to you today. So I've been working in 2 main groups in Pelotas. So within the epidemiology program, I work both with the International Center for Equity in Health, where I'm going to show you more of the findings on a global health perspective, because there I've been analyzing these cross-sectional population health surveys that are conducted in low and middle income countries. So in particular, the DHS surveys, which are conducted by USAID, They have been collecting data on violence in a very standardized way since 2010, and I've been using these surveys to investigate my research questions and monitor violence against women, more specifically intimate partner violence in the context of these countries. And the other group I've been affiliated is the Human Development and Violence Research Center, where I'm doing more on this, looking the birth cohort data and how violence impacts children outcomes with this prospective lens, let's say. So just to contextualize the field before I share the findings of my own research with you, fortunately, we have been this increased recognition that violence against women is an important issue to address. And if you want progress in many other problems like maternal and health outcomes, we need to address violence against women and intimate partner violence because it's one of the most common, so it's very important. And then I would say that in a global health perspective, there were 2 milestones over the last 3 decades in increasing this visibility on violence against women. We had the launch of the Sustainable Development Goals in 2015, and luckily one specific goal on eliminating all forms of violence against women and also children. And then in 2016, we have this WHO plan that we need to address these issues in the health systems, and then increasing data collection and understanding more on the nature and the consequences of violence to have more visibility. In terms of the data that we have on the field, so until very recently, because they published a new report in 2020, but until the SDGs were launched, this is the data that we had, saying that 1 in 3 women experienced physical and or sexual violence by a partner or a non-partner during their lifetimes. So this data was from 2013. From WHO. It was based on a systematic review where they included different studies with different methodologies and about 30 low and middle income countries. So with the launch, specifically on the Sustainable Development Goals, if you enter a bit more on their scope, we have this target 5.2 on the elimination of all forms of violence against women and girls in public and private spheres. So it's a target under the goal 5 that's on achieving gender equality, right? So it's a recognition that violence impacts across all other SDGs. And very important, they include indicators that we need to track to monitor the progress of countries and in order to achieve this goal. So it's within this context that my work in the International Center for Equity in Health fits. It's trying to help monitor violence levels in these countries and also encouraging data disaggregation, because it's very important that we found the groups that need more interventions under this scope. So, well, since there, we had an increase in data collection. We had many surveys, including this violence against women module, specifically the DHS that I told you. And in 2019, I was invited to lead this work that was like the baseline for countries to have a baseline that we can track now how countries are going to be to achieve the goals, right? So it was part of a collection called Leaving No Woman, No Child and No Adolescent Behind, in partnership with the Countdown to 2030. That's the deadline for us to achieve this very ambitious goal, of course. But so one thing that we needed to incorporate here in relation to WHO estimates, and we have also people here in the paper that are from WHO, but is to include the emotional intimate partner violence estimates, because we had a lot on physical and sexual violence, but not psychological, and also perform this data disaggregation. So that's why what we did in this paper, basically. Just entering a bit on the methodology, we looked at all surveys that had the violence module implemented. So we took the last survey from each country. So we had 46 countries with data. And just so you can have an idea, the violence module is applied to 1 woman per household. That's following WHO safety recommendations to data collection on violence against women. Also, the questionnaire is applied only if privacy is obtained. And we have this very act-based questionnaire. And just a point here that the field is doing like this, questioning women about violence by asking specific acts. And that's because we know that women are more prone to disclose violence if we ask in this way, right? So the DHS is implementing in this way as well. For the paper, we look at the 2 main indicators. So psychological violence, separate from physical and sexual violence, because we wanted to also look at the patterns of psychological violence. And different from the estimates we had that were for lifetime violence, we wanted also to look in the past year estimates. That's more close to what women is experiencing at the moment. So I like to think, before I enter into the results, I like to show this figure because as other behaviors that are very delicate with violence, what we are seeing is just the top of the iceberg. We know there is much more than we can see as researchers, but compared to, let's say, admin data, surveys is still better because they capture more of this violence, right? So just for us to have an idea that that's what we can have on the field, the best way we can address so far. I think we have a lot to improve on methods, but still surveys can capture a bit more than admin data. They tend to be more severe for most countries. And so I picked some of the findings of the paper to present to you in the interest of time here. So this is a map with the prevalence of physical and or sexual IPV in all these 46 countries. And I just, the darker the color is the country with higher prevalence, but I put here just the top 5 so you can have an idea that are Colombia, Congo, DR, Afghanistan, Timor-Leste, and Papua New Guinea. And we have a combined prevalence of 21%. So for some of the countries, let's say Afghanistan, we have 1 in 2 women experiencing physical or sexual violence in the past year reported. So we performed a series of data disaggregation, which are presented in more detail in the paper, but I'm bringing here the stratification by wealth quintiles. That's the most traditional way we use to show socioeconomic inequalities at the International Center for Equity in Health. So here, I know it's very small, but I will show with a zoom in the next slide. But just for you to look for the colors, the quintile 5, that's the richest group, is the yellow one. And the darker, more black, is the poorest group. So we can see that it's all aligned, the yellow dots on the left. We have the lower prevalence of physical and sexual violence and also psychological among those women that are richest, right? So we know that violence is really concentrated among the poorest, but the intention here is to show the size of the gaps between the groups. So in particular, I highlighted India. We have gaps that more than 20 percentage points between the poor woman comparison to the richest. And here, the same graph, but with a zoom on the countries from East and Southern Africa. Besides the perhaps obvious finding of violence being concentrated among the poorest, an interesting aspect to look here are the different patterns of inequalities. So if you look at South Africa, for example, we can see that the prevalence of physical and sexual violence is gradually increasing from the poorest to the richest the opposite, from the richest to the poor women, right? But in Burundi, for example, although the poor concentrated the higher prevalence, you can see that just the richest group that is being left behind. So this is very different in terms of policies that we want to address. So it's the same risk factor, but countries are in different stages in terms of policies that we want to implement, for example. And here, another way to show inequalities, that the same data, we are looking at wealth inequalities, but in the red line, for example, is the equality line. So no difference between the richest and the poor. We have on the y-axis the slope index of inequality. That's a measure of absolute inequality. And the x we have physical and sexual violence. So I highlighted the countries that have higher prevalence and also huge inequalities, that are India, Uganda, Gabon, and Timor-Leste. And if you have some doubts, because it's quite concise in terms of methodology, the presentation, if you have urgent clarifications on the graphs, you can, yeah.
Hi, thank you. I think this is really very, very interesting to see, and thank you for this presentation. So I have several questions. One is, when looking at this, I'm surprised not to see Brazil on this one, because inequalities in Brazil are, at present, quite stark. But then how does it not translate into inequalities in IPV?
That's because Brazil is not here because it doesn't have a national survey. So we don't have their data here, but I'm going to show findings from Brazil later.
Okay, and then if it doesn't disturb your presentation too much, I didn't 100% understand what you presented in the previous slide.
The previous?
Yeah.
Okay.
So particularly, my interest was when you talked about India, or even these when Burundi, so understanding what the correlation is that you're actually presenting, if you could explain, because essentially, yeah, could you explain again?
Yeah, so this is very simple statistics. What we are doing is the prevalence according to the wealth quintiles for each country, right? So you have the population and it is split in 5 equal groups in size according to their wealth index.
So in South Africa, it's more equally distributed across the quintiles rather than where in Burundi, where we see it's really in the sort of poorest is the strongest and the richest have the lowest.
Yeah, the difference is that in both countries, we have the richest with low prevalence in comparison to the other groups that are poor, but very different patterns, because in Burundi, it's only the richest that have low prevalence. All the other quintiles have high prevalence. And in South Africa, it's gradually increasing. Yeah.
Yeah.
So just to summarize the findings of this paper specifically, we have looked into different data disaggregation. I showed you wealth inequalities, but we have looked at empowerment. That's just briefly the graph I put here. We see very high prevalence of violence among women that in the low empowerment groups. So we divided the women in 3 different groups according to their empowerment, and we see consistent association, so less among empowered women. And we also look at current age as an stratifier. We have most countries showing higher prevalence among adolescents, but it's not very consistent according to age. And we also look at polygyny status, and we found that in families where there are more wives, there is more violence too. But I encourage you to look at the paper if you wanted to see in detail more of these stratifications, because I want to show you more things here. So with the same data, but adding a few countries more, because we had more surveys after this first paper. So we wanted to include more. It's like the first paper, we decided which were the stratifiers we want to look, right? So wealth, age. And in this next paper, we just choose 15 risk factors that are from the literature that are risk factors for violence, but had available data on VHS. And we put it all them, and with this methodology, that's a decision tree approach, the tree comes with risk factors that are more important. So we don't choose the tree, the methodology choose the ones that are more important. And we wanted to see where violence is concentrated. We had this combined tree for all the countries that I show if we start at the top. So we have our pooled prevalence, 21% for all the countries. And then we move to the right. If the woman witnessed father to mother IPV in her childhood, so we move to the right and we have a prevalence of 37%. And if these same women were from a low empowerment group, we move to a group where the IPV prevalence is 43%. So this group 4 is the group that concentrates the higher prevalence of violence. And with only 2 variables, we can identify here 25% of all the women that experienced violence, right? This is the combined tree. We did 1 tree per country. So I'm not able to show you today all of them, but I wanted to show just an example. Let's say Papua New Guinea. We have here like a country profile that we prepared for all countries. It's in the supplement in the paper if you wanted to see all of them. But we show some demographics. That's the prevalence of physical and sexual violence, for example, and also separately. And then we show the percentage of women according to education and some other characteristics. But I wanted to show that only with 1 variable here, the tree came with a partner drinks alcohol. So we have a prevalence of violence in Papua New Guinea that's 48%. But if the partner of the women drinks alcohol, we go to 70%. And in this group, we have 71% of the women who experience IPV in this country. So I think it's very important because then we can think in this country, maybe we can address both things together. If you are having some policy like for alcohol consumption, we can address violence too. So in this sense, I think it's very interesting for policymakers. We also had a case study in the same paper for Kenya. We invited a researcher from there because this country, we found a very large inequalities by regions of the country. So very different prevalence across the different regions. And we try to understand what are the policies that are being implemented there. We discuss in the paper to justify the subnational differences. And this happened for a lot of countries. I will show just a summary of all the trees we have for the 48 countries. But subnational differences appeared in the tree for half of them. And then we have partner alcohol use, and if the women witnessed violence during childhood, and then age, and so on. So just a summary of the trees. Well, leaving a bit the global perspective from low and middle income countries and entering more on Brazil. So we have data from the birth cohorts there, and because it's a prospective study, we are following all these people since birth, we can say much more in terms of consequences, determinants of violence, right? So just for you to have an idea, we are following all this about 20,000 families. We have the first cohort set up in 1982, and then the last one, the 2015, is the one that is collecting more data on violence, and that's the one I'm going to show findings to you. But just in Pelotas, we have 99% of the births occurring at hospitals. That's where we have the first follow-up of these children with moms and the baby. And then retention, over 99% agree to participate on the studies. And then 82, we have people with more than 30 years now, and it's still quite 70% of them in the study. So here are the different follow-ups for each cohort, so you can have an idea. We are also able to analyze trends between them. And more specifically, the 2015 that I'm going to show data, we had the last follow-up in 2021, that when children were 6-7 years old. And that's the first cohort that we had a pregnancy follow-up to. So following since pregnancy. So I took 3 studies from the 2015 cohort that I've been involved, and I wanted to show you some of because I think one of the ways to give a family had 4 or more of these risk factors on the list. Another thing we wanted to look in the cohort, because the data now allows, is the intergeneration transmission of violence. So we look at if these moms, when they were a child, they experience adverse experience in their childhood. So we look at their own experience of violence, also some of other adverse events in the family, and we wanted to see the later risk of being a victim of violence, and also their children experience child maltreatment. So we found very consistent association. The more the adverse events the mom experienced, the more the risk she's a victim of violence, and also there was child maltreatment among their children. And lastly, I wanted to show this study. That's the last one I was involved before being a mom, because I now have a 9-month baby, so I'm just coming back from work. So this is part of my Wellcome Fellowship. I look at the maternal IPV victimization when the children are 4 years, and how this affects the parenting of moms, both at 4 and 6-7 years, so more long-term too, because we used the data from the last follow-up of these children. And we found very consistent associations with parenting, so less consistent the mother is. There is a poor mother-child relationship quality and more harsh parenting among these moms. And we also look at the emotional violence separate from physical and sexual. And I think this is very important, because we can show that emotional violence actually has the same risk on these outcomes as physical and sexual. So very important to start in the field showing these effects in a separate way, right? I think all of these findings, both from a global health perspective and more the cohort, give support to what is being recommended in terms of implementation for violence prevention. And I think it's very important to think about the new generation if you want to change. But of course, we still need to think about what to do with victims of violence now. Next steps of this work, I wanted, as part of my Welcome To, I will look at the longitudinal associations of maternal IPV victimization with child development and mental health outcomes as a next step. I also want to start looking at the trajectories of IPV, because we now have more data points being collected for these birth cohorts. So it's something in the field that we don't have a lot, many time points to see how are the trajectories of violence among the same people. And something I really wanted to do is to start collecting more data on fathers, because I think it's really important. We focus a lot on the moms. And in this paper on the parenting, for example, it was very challenging for me to discuss why are mothers being victims of violence more harsh with their children. We put all the guilty in moms, but we don't really have data on fathers to look more broad what is happening in the family. So we know moms are the main caregivers, and they are victims of violence. They will be more stressed. They will be more harsh, but we need data on the fathers too. And that's why I think we need to involve more men in this research and also to construct the field, because sometimes we are a lot of feminists, but we really need to involve men to have a construction that is going to last. And that's it. Thank you so much for coming, and those attending virtually too, and open for questions.
Thank you so much, Carolina.
Thank you.
So, can we see who's online who has questions? Sorry, I'm speaking to Sam and AV. We can't see who's online. But if there are questions in the room, please do put your hand up and introduce yourself, your affiliation, and ask Dr. Coll your questions. Please go ahead.
Hi, thank you so much, Dr. Coll, for a very fascinating presentation indeed. I'm Sokuro BC. I'm a second-year DPhil student in the Department of Social Policy and Intervention. I'm really very interested in the outliers for the results that you presented on the inequalities, the wealth inequalities in prevalence of intimate violence. So, excuse me. And with regards to West and Central Africa, where the results seems to be the opposite, if I read your charts correctly, so you'd have higher risk of intimate partner violence among women from higher wealth quintiles. So, am I correct?
This one?
Yes, this one. So
No,
if you look at the results for because Nigeria, Angola, Burkina Faso, and a couple of other countries, it seems like women from higher wealth quintiles had higher risk of intimate partner violence. So
no, actually lower prevalence. If you look at the yellow dot, that's the wealthiest women. So, and here we have the prevalence. So lower prevalence usually for the richest women, except here in Mozambique, we have this quintile 2 with lower prevalence. But for the other countries, is the pattern of lower prevalence among the richest.
So the West and Central.
West and Central, okay, sorry.
Yeah, so you have Nigeria, I think. I mean, I think it was clearer in the graph where you had.
Yeah, it comes more clear in this graph. Let's see.
Yeah, so
here.
Is above. So
yeah.
It seems like that's Burkina Faso, Nigeria, Sierra Leone, right? Mozambique. It seems like high wealth quintiles are associated with.
Yeah, you're right. All the countries above the red line have the opposite pattern. The gaps are not really high. But you are right, and.
I'm really very interested in what's like the usual prevalence of is prevalence of violence very high in these countries. I'm assuming yes, and the implications for policy making. I mean, why I'm really thinking about this is in your decision tree. How do question whether it was supervised or unsupervised, or whether you consider context specific factors for each country? Because if you pull all of this together, wouldn't it mask patterns with these countries and the implications for policy making? Say, like if programs are targeting low income women for particular contexts, whilst the reverse is the case in countries with high prevalence of violence. I don't know what you're
Yeah, so for the trees, we actually have one country profile per country. That's because of this. So we had the pooled tree we present in the paper, but the most interesting for policymaking are the individual ones. And because then the tree come with what's most important for that specific country. And I don't remember Nigeria, but looking at the supplement, we have one country profile for Nigeria, and I can show you later if you want. Yeah.
Oh, please go ahead, and then Julia.
Hello, thanks for this talk, and I apologize, I couldn't make it on time. I'm Simon Honigman. We met the other day from the Perinatal Mental Health Project in South Africa. I'm curious to know whether you are going to be examining or have already different types of maternal mental health conditions, and whether you're going to be disaggregating or setting up studies to distinguish between maternal anxiety disorders versus depressive disorders versus post-traumatic stress clusters, because I think we may find different patterns according to the mental health conditions. Is that something you're thinking about?
Yeah, so unfortunately for the DHS data, the National Household Surveys, we don't have data on mental health. That's, but I really wanted to analyze. In the cohort, we have these different data. So we have depression, we have anxiety and other conditions that we can look into. In this next paper that I'm going to look victimization and mental health outcomes of children, I want to look mental health for the moms as a mediator. It's going probably to be depression, but we have data also on anxiety and other things. But I really wanted to clarify these pathways between mental health and IPV in both directions in one next stage. Yeah.
Oh. Alan, please go ahead. Alan, if you have your hand up, please go ahead.
Yep.
We can't quite see you.
Can you hear me now?
We can hear you. And now we can see you too.
All right, great. Thanks very much. Thanks, Carol, for such an interesting and clear presentation. Could you say a bit more about how you measured female empowerment? In the slide, you talked about empowerment being an important index, and perhaps just try and explain a bit of the association that you found between increased empowerment and lower violence.
Yes, sure. So this is an index we developed at the Equity Center. It has 3 dimensions, actually. It's decision-making, social independence, and attitudes against violence for the women. What I'm bringing here is the domain of attitudes toward violence. So these are questions about specific situations where women is asked if she justifies the husband beating in, let's say, when she burns the food, when she neglects the child. So we take these questions, we have this index, and then we split the women in 3 groups here. So low, medium, and high empowerment. So this one specifically is the attitudes to violence domain. But we have a paper with the empowerment index, which we're more interested. It's a survey-based. Go,
Can you say
Alan.
a bit more about the relationship with the finding itself?
The finding itself. So yeah, so the golden dot are the women more empowered.
No.
Lower prevalence of IPV among more empowered women, very consistently. Yeah. Seems obvious, but sometimes it's not, because it's not a relation. Sometimes if a country is more conservative, for example, we have women being more empowered, at the beginning can be more violence. So, but that's, we found here more empowerment, less violence.
Thank you.
Julian, then I'll come to you.
Thanks, Carolina. I just have 2 brief questions. The one is on more methodology, and I wanted to hear a little bit more on whether there's been any improvement in measurement of IPV, or whether we're basically always measuring with survey questions, and that's as good as we can do. The second is related a little bit with what Alan was saying, but just more looking at some of these risk factors, whether you're also thinking about more interventions, and what sort of risk factors do you think are the more kind of cost-effective ones to target in interventions?
Yeah, so measurement is really a thing that we need to improve in the field. I'm looking to Amia, who is also early career as me, and we wanted to improve the field in this. And I think now the DHS is including more questions, not only for partner women, that's one advance in the field, including questions for all women, including those not with a partner. And but we need to explore more psychological violence, but also the frequency, the intensity, many things. That's only the start in the field. Yeah. And about the risk factors, I think, well, we have that's another thing we need to advance in the field in terms of interventions that are cost effective. But I don't have the answer to you, but I think we need to start thinking how to address violence in the ones that are already working. Let's say alcohol consumption, for example, it's one good idea. Parenting, we need to address, take the parenting interventions and start thinking violence against women and children together. That's...
Please go ahead.
Thank you for your presentation. I think it's really important work that you're doing. I just wanted some clarification on your slide on the ACEs themselves. You could please. Thank you.
This one?
Yes. So my question in particular about the ACEs was if you had measured what type of ACEs were particularly associated with the increments in the transmission of violence, because I'm particularly interested in ACEs that relates to it.
Yes.
And second part of my question would be, because of the almost vicious cycle of, say, childhood ACEs being associated with more violence down the line, do you have any thoughts on how there could be some form of early intervention such that the cycle can be broken at some point?
Mm-hmm. So we did in this paper, I showed only these results, but we had 3 different ways we worked with the ACEs. So one is the score, but we also had the individual ACEs risk in the paper. So we can see that the risks that are higher are those related to the man having experienced violence itself during childhood. So physical, emotional, and sexual. Yeah, and the other question, sorry.
I was asking if you had thoughts about policy making as relates to early intervention, such that the vicious cycle.
I would say parenting, very important. Yeah, I think the parenting interventions are a good way to start working with this new generation, and also with schools. Yeah.
Yes, please go ahead.
Hi, my name is Nicole Truba. I'm at the NAFTA Department for Women and Reproductive Health, and I work on perinatal mental health and women's mental health in the global context, alone middle-income countries, particularly at the moment in India and so rural India. And what we see in a study that I'm leading in rural India is that we looked at how to improve mental health outcomes for women. And what we found is that there's a massive amount of even unspoken and unassessed domestic violence, but it's so common that essentially it's very prevalent, we're being told. So one question I have for you, when you presented the data from India on the national survey data, is how this was collected, because it was really high, so I was surprised to see that. But then if you know anything more about the actual data sources, how they were collected, where they were collected in India, and then my other question would be, what we also saw is that domestic violence and mental health outcomes for women and poverty and other social determinants, essentially, of health and equity all influence each other. And I mean, I would assume, sort of looking at your data a little bit, that might be the case also in your study from Brazil. Do you have any ideas on, say, for instance, in India, a lot of the men, we're being told, in rural India are not employed, so the money that they have, they use then often for alcohol, and that increases domestic violence in the homes, which reinforces all the other issues that we see. Do you have any, are you looking at all at these cross correlations and how to address them, or do you have any other thoughts what we could do to improve the situation?
Yeah. So data collection, they are kind of standardized in these national surveys. So it's being 1 woman per household, privacy, only if privacy is obtained at that moment, the woman is answered the questions. And but of course, we have some particularities on the countries. Not sure if you, Amia, know more about the India context. You want to say a bit?
I mean, I think this graph really says it all, right? Like, there's such large sub-regional differences in India. I think it's hard to generalize about men or about context within the country. And I know, Carolina, you've done a lot of work in trying to sort of parse what's happening at the household level and then also what's happening at the contextual level.
Yeah.
And the India survey actually is also a really interesting data source because it's representative at so many different levels. And so I think a lot of folks seem to be asking about the contextual factors. And I think the India survey actually allows us, for the first time in many countries, using these data to start to unpack some of these contextual factors. I don't know, what do you think?
Yeah, I agree. And on the mental health aspects, I want really to explore these intersections, but I don't really have the answer now. I know there is a group here in the UK, I think Bristol, they are really studying these links between mental health and violence and trying to address more of this jointly on the health system. So might be something to look more.
Oh, please go ahead.
Excuse me. My name is Ben. I'm in the public policy program. I'm a defector from the Department of Social Policy and Intervention, which sounds like it might be very similar. I'm just wondering about the decision trees. How do you choose like how many layers they have? So are these only factors that were like statistically significant? Because you said you didn't get to choose what was in the tree. So was it set that there would always be two for every country, or how did that bit play out?
Yeah, so the tree actually chooses the methodology, but we included the 15 risk factors for all these countries. And then the tree comes up with the ones that are significant and that concentrates the higher risk of violence. More details on the methodology and the statistics I can give it to you later, but is that not the layers is chosen by the tree actually, yeah. The intention is to choose the smaller group with more homogeneous levels of violence that we can find. So, yeah.
Oh, please go ahead.
Thank you so much, Carolina, for the interesting presentation. I'm also Brazilian, so it's great to see this rich data that you have. I'm actually working with a similar cohort. Maybe you've heard about it, the Brazilian cohort for children at high risk of psychopathology in Porto Alegre, São Paulo, and they have a lot of similar data. So I was wondering, one, because they have data both on mental health outcomes, but also on ACEs and violence. So it seems very similar and aligned to what you want to do. So I was just wondering if you think of collaborating with them or working with this data sets. Then my second question is, have you heard or seen studies, qualitative studies that could potentially explain the mechanisms behind these risk factors and the quantitative data that you found?
Yeah, so good to see one Brazilian, and I didn't know about the cohort. Interesting. I will have a look into it. I think in terms of sorry, can you ask your second question again? This is my postpartum brain. So
It was if you've seen qualitative studies.
Qualitative studies, right. I saw one doing this study on IPV and parenting. So I looked into many qualitative studies, but they were looking specifically on the pathways, like why are these women being victims of violence, have more these outcomes on parenting, but also many strategies of resilience. So that's a thing I really want to explore too. Some women that are victims of violence are very resilient and they have other outcomes. So the qualitative studies are more on this sense, the ones that I found.
Do we have any questions online? Sam, or is it Alan? That's
It's me.
Alan.
Am I?
Yes, go ahead, Alan.
Carol, you mentioned the issue of education and educational interventions, especially with boys and with men, and just wondered, are there any ones that have been really successful? Because it seems that starting with the women is always going to be a bit, you kind of, I don't know, it's about closing the stable door after the horse has bolted. But I mean, it's that we have to start at the beginning. We have to start at school and much earlier on in socializing. I know that it's stating the obvious, but just are there any interventions that you know of that have been successful, or how they've been set up?
Yeah, they exist. I think more on the context of African countries. We can say they are really successful, but because they are very small, but some of them have a success in changing some social norms, for example, and also some working with more conflict resolution between couples. So that's the kind of intervention, but it's still very small in the field.
Thank you.
Yes, please go ahead.
I have a question about your methodology. I'm Jun Kobayashi at Nissan Institute for Japanese Studies. At the last part, you showed a cohort research with a 99% participation of a newborn child.
Yeah.
It's surprisingly high. So I wonder there might have been any certain coercive factors or not to involve those so many people.
Yeah, so it's really high at the beginning because we go to all maternity hospitals in the city, and it's like the women are there, and then we interview at the hospital. So it's like 99% of them accepting to enter the study. Then in the next follow-ups, it still is very high. Maybe it's something from a low and middle income country. But we usually encourage people to go to the research center, and we give some of the results. We give, at some point, some money to encourage people to come. We really try to bring all of them. And because people don't move a lot from Pelota City, it's being like this. So the 82 cohort, now they have more than 30 years, and it's still around 65% of all of them involved in the study. Yeah.
That's because those mothers are interested in your research and they want to show their voices, right?
Can be, yeah.
Thank you.
But it's just following on that, so it's a cohort about many other questions. It's not just
not only on violence.
So it's also like social context and education. So I guess like how you frame the involvement also probably also helps.
That's a very good point, Julia, because Julia also worked with our cohort data at some point. And that's it. It's a very big questionnaire involving many health outcomes and behaviors, not only violence. And actually only the last one, the 2015, that's more focused on violence. Yeah.
Amazing. Okay, so I think that's everyone's question. But Carolina, if you don't mind summarizing a little bit where your research is going, the cohort studies, the DHS studies, and just reminding us a little bit of the take-home message that we should take from your presentation today.
Yeah. So I would say we have a huge between country and within country inequalities in violence. I really wanted to start looking, still a few countries that have data on both violence against women and children in this type of surveys, but I want to look at this co-occurrence also in the DHS and more on this, because I think putting the two types of violence together also gives more visibility to the field, and it's very important to address both of them together. And in terms of the cohorts, I think they start showing the impacts on children. I want to show more on mental health outcomes for the children and also child development, and also keep collecting data on violence on these same women to see how are these trajectories over their life course and how it's over the life cycle. Yeah.
Amazing. Thank you so much, Carolina. And thank you everyone for coming.
Thank you.